Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Our topic today is the recording of EMG activity in the diagnosis of REM sleep behavior disorder. So in patients with suspected dream enactment behavior, we confirm the diagnosis of REM sleep behavior disorder by detecting excessive EMG activity during REM sleep on a laboratory polysomnogram. But how much is excessive? Can sleep specialists inexperienced in diagnosing parasomnias assess this accurately? To discuss this problem, my guest today is Dr. Eric St. Louis, Professor of Neurology at Mayo Clinic and a board-certified sleep specialist. Eric, could you start by helping our listeners understand the difference between REM sleep behavior disorder and REM sleep without atonia?
Well, sure, Mike, and thanks for having me today on the podcast. REM sleep behavior disorder, or RBD, is a clinical diagnosis that requires the presence of clinical REM sleep behaviors, either evident by the history or observed during the in-lab polysomnogram. Specifically, these so-called dream enactment type behaviors are complex focal and motor behaviors during REM sleep that often mirror the contents of a dream when that is recalled. The International Classification of Sleep Disorders, third edition, also requires the presence of REM sleep without atonia during polysomnography, which is defined as abnormally excessive muscle activity during REM sleep. Throughout the rest of this, I'll refer to REM sleep without atonia by the shorthand RISWA or RWA, which are synonymous abbreviations and a lot easier to say. Importantly, RBD is a clinical diagnosis requiring abnormal sleep behaviors, and no amount of polysomnographic RISWA without such behaviors should be regarded as diagnostic of RBD in and of themselves. It's actually not uncommon to have abnormal amounts of RWA encountered incidentally during the polysomnogram. The emerging terminology for such abnormal RISWA without evidence for clinical dream enactment is now known as isolated REM sleep without atonia.
Okay, so we generally measure surface EMG activity on a routine polysomnogram in the submental muscles, of course, and in the anterior tibial muscles of the leg, and we do that in every polysomnogram for sleep apnea or for other reasons. Should any additional muscle channels be added when we're specifically suspecting REM sleep behavior disorder and doing the study for that?
Well, yes, when studying patients with parasomnias, the additional placement of arm EMG sensors, especially over the flexor digitorum superficialis, or FDS for short, is of crucial importance. Arm EMG recordings from the FDS have been shown to greatly increase the accuracy of RBD diagnosis. So the FDS is a forearm muscle that leads to finger flexion of the second to the fourth digits at the metacarpal phalangeal joints, while leaving the fifth digit, the pinky, extended. And for those of you who've seen video, you can see my gesture here, which is like waving bye-bye with the second through fourth digits and leaving an English T pinky. Or making, if you're perhaps younger and more hip, we would say it's a surfer dude gesture. You can easily feel the belly of the muscle about a third of the way up the forearm, just mesial to an imaginary line bisecting the third digit and the middle finger, up to the middle of the antecubital fossa. So as the patient is instructed to activate the muscle, you can place the sensors there over the spot about 1 to 2 centimeters apart where you can feel the belly of the muscle.
Great, that's very helpful, and especially people watching the video to see where the placement is. Do we need to formally quantitate the amount of muscle activity during REM sleep? You know, that's certainly intimidating for people who've never done it before and takes time. How often can a polysomnographer, an experienced sleep physician reading polysomnograms, make a reasonably accurate diagnosis of REM sleep without atonia, RISWA, by just a sort of general gestalt, an eyeball review of the REM sleep components of the tracing, looking at those muscle channels?
Well, I think you're right that scoring this muscle activity for clinical settings is often not pragmatic. We realize that busy clinicians don't always have either the experience or patience or the time to quantify REM sleep without atonia. So I'd say the first important step in the visual recognition of this activity is to rule out mimics of RWA that occur with spontaneous or breathing related arousals, which during REM sleep, by definition, an arousal should be considered physiological muscle activity that's necessary to recognize the arousal, and this should be excluded from RISWA recognition and diagnosis.
Yes, you know, so many of our patients with suspected RBD are older men, and many have sleep apnea as well. So when I order the study for both sleep apnea and for RBD, I generally choose a split night protocol, and I'm interested in the REM sleep in terms of the atonia only in the second half, once we've eliminated all the sleep disordered breathing with CPAP. Is that your sort of approach as well?
Well, I think that's exactly right. Often for clinical settings, you want to look at the cleanest portion of the REM that would have the least arousals. And in the setting of sleep apnea, it's generally the case that in a split night polysomnogram where the second half is treatment, you'll have many fewer arousals and a much better ability to judge the presence or absence of REM sleep without atonia.
So let's say we have a difficult record where it's not entirely clear, is the muscle increased, is it not? How do we determine whether EMG activity is quantitatively excessive on a single 30-second epoch?
Well, great. Let's, before speaking to that, I'll start with a couple of basic RISWA housekeeping definitions. So RISWA or RWA, we really say is of two basic types, and these often overlap in the real world settings. The first type is phasic muscle activity. It's also been known as transient muscle activity. These are shorter bursts of muscle activity that exceed the lowest REM sleep background voltage by at least 2 to 4-fold times greater in amplitude, and that have a duration between 0.1 seconds, that's 100 milliseconds, and either 4.9 or 14.9 seconds, depending on the laboratory's method. The second type of RWA is tonic muscle activity, which is a lower voltage, longer duration muscle activation, double the lowest REM sleep EMG background voltage, and lasting at least 15 seconds, that is, at least half of a usual 30-second epoch. So the traditional research scoring methodology for RISWA has involved dividing the usual 30-second polysomnogram epoch that we're used to using for sleep staging into 10 3-second partitions or mini epochs for the phasic muscle activity scoring. This is done in a bin-like fashion where the 3-second mini epoch bin is considered positive if it contains a scoreable phasic muscle activity burst or not. And when one does so, we will score the mini epoch positively that contains a phasic muscle activity burst that fulfills the voltage, amplitude, and duration criteria. And the usual approach has been to score all such mini epochs positively wherever they occur and exclude muscle activity related to arousals as artifact. Since the two types of RISWA, phasic and tonic, also frequently overlap, researchers have also proposed a more parsimonious single type of RISWA known as any muscle activity, which is simply defined as either phasic and or tonic muscle activity, so phasic or tonic or both muscle activities lasting between 0.1 and even longer than 15 seconds, and then scoring these by these 3-second mini epoch bins. I actually find this way of thinking about RISWA to be quite helpful, especially when you're mentally, visually scoring a clinical sleep study, because then I don't have to get so far down into the weeds of the precise type of activity or if it's definition or measuring it, and only really need to think about ensuring that I'm discounting all muscle activity that's related to arousal-related artifact, be it spontaneous or breathing-related arousals, and not considering that muscle activity in my thinking about the case.
Yes, thank you. That's very clear. Now, before all our listeners who don't do this very often sort of get glassy-eyed over these 3-second mini epochs, I should say, in my experience, and of course I'm I'm fairly experienced in looking at parasomnia activity. When I do clinically quantitate, when I'm just not sure on eyeballing, it doesn't actually take that long. If I've got a resident or fellow with me, I have the fellow keep score with a pencil. But if not, I'll do it myself. And I can eyeball those 3-second mini epochs pretty easily in the course of a 30-second page. And I just quickly count on each page how many of them have increased activity, phasic or tonic, doesn't matter. Make some marks on a paper, and then go to the next one. And going through the REM sleep of a record, it probably doesn't take me more than about 20 minutes to do it. Now, for research purposes, that's probably not quite accurate enough. You have to measure, but clinically, it doesn't take all that long when one's used to it. Would you agree with that?
Definitely. I think I do the same thing in my practice. When you're just not sure and you have a borderline case, then I think the quantification can actually be quite useful. And to kind of make it practical and easy, I would just consider the sequential 3-second mini epochs and consider all the muscle activity channels at once and not try to get into the weeds about separating chin from arms, from leg.
Mm-hmm.
Wherever it occurs, you count that bin positive, and then I simply make a little tally mark, a little hash mark on a page. And then if you want to quantify, you can simply add up all those and divide by REM sleep time, and you get a proportion or a metric of the positively scored REM sleep without atonia throughout REM.
Okay, so that gets us to the next question. So we've now done that, and we've now worked out what percentage of total REM time has got mini epochs that are abnormal. What is abnormal? It's easy to do the test, but what is normal? Some suggested cutoffs are given if you read the third edition of the ICSD, but it remains an area of quite uncertainty to most sleep specialists. Now, the Mayo Group, under your leadership, has published a number of studies on this subject. Can you explain how appropriate cutoff values are sort of determined for different uses?
Well, sure. First, I'll just speak to the idea of, whether you're scoring it for a research setting or
Mm-hmm.
for a clinical setting. And in most research settings, one would want to consider likely a highly specific quantitative RISWA threshold to ensure high accuracy of the diagnosis and for inclusion into something like a prospective cohort study with rigor for the diagnosis, or perhaps especially for an interventional clinical trial. You really want to have that degree of confidence of a specific value. However, for some research purposes, such as maybe an epidemiological prevalence study, you might accept a more permissive diagnostic threshold, one that's maximizing the sensitivity for inclusion of participants and including prevalent cases. Then you have clinical settings. Given more intimate knowledge of the history by the clinician, you come in with that lens, and you might then particularly be prepared to accept a more permissive approach and value that maximizes the sensitivity, or the best trade-off between sensitivity and specificity. I think is a pragmatic approach, especially if you know the case is in a known case of Parkinsonism or cognitive impairment syndromes, or the company it keeps that you would expect to find an RBD case within. We have in our most recent study published within the year in the Journal of Clinical Sleep Medicine in the February edition of volume 20, we found in our most recent study analyzing diagnostic thresholds between RBD cases with isolated RBD and controls, that for this concept of RISWA-NE metrics, that's the, remember, phasic and or tonic muscle activity scored within a 3-second mini-epoch, that the thresholds for the submentalis or chin muscle vary between 7 and 14%, and these have quite high accuracy for the diagnosis. The variability is explained by whether you want a more sensitive value, the lower one, or a more specific one, the higher one. So 7 to 14% is a pretty reasonable range for that muscle alone. You have undoubtedly heard about the SINBAR combination of the submentalis and the flexor digitorum superficialis, the arm muscle. And so if you consider any muscle activity divided over those two channels, then you get thresholds in the range of 15 to 27% as having the best performance for distinguishing RBD from controls. However, if you were looking for even another shorthand way of trying to check the accuracy, we have found that longer bursts, longer phasic muscle activity bursts that approximate 700 milliseconds or 0.7 seconds. Let's say for ease of remembering, we just rounded up to a second. If you're seeing second-long phasic RISWA bursts, that alone is a pretty good giveaway that it's likely a patient and not a control.
Oh, that's very helpful. But so let's get practical now. Most of our listeners are not doing research on muscle activity and REM sleep. Most of our listeners are clinicians who want to have simple metrics to work with. So for practicing polysomnographers, what simple metrics would you suggest? And using these metrics, what numbers should our listeners remember as their most appropriate clinical cutoff for the diagnosis of REM sleep behavior disorder? In other words, if the muscle atonia is above what sort of point on the various metrics you're going to suggest to us?
Great. Well, I'll give you one answer in 3 parts to this question. While I encourage and emphasize a pragmatic approach to RISWA recognition and scoring, I think you need to start with simply visually identifying phasic and or tonic RISWA. And I think considering it as this any muscle activity, phasic, tonic, either or both, when you're calculating your metrics is the way to go. And for the total RISWA for the whole night, if you estimate it visually this way, the numbers that I think are easy to hold in the head is if you're considering the chin alone, 10% is a good number that is reliable for accurate diagnosis. If you're considering the SINBAR montage or the chin plus the arms together, those two channels, 15% seems to be a good cutoff for those muscles. And if you consider the chin, the arms, and the legs being a little less specific, that number rises a little bit to about 33%. So if you think of any muscle activity collapsed across those 3 channels, 33% or a third of epochs is a decent number to hold in the head and remember as a reasonable diagnostic threshold for RBD.
So 10%, 15%, and 33%, and each of these would be valid depending on the sort of way you want to do it, looking just at submental, looking at submental and arms, or looking at all 3, which is a little more difficult when one's visually looking at tracing mini-epoch after mini-epoch. So I think if one wants the simplest is to just look at a single channel, which is the chin, though the combinations may be a little more accurate, but that's very helpful. So if chin alone above 10%, you'd think that's probably predictive in the right clinical setting for the presence of RBD. Wonderful. So Eric, what final messages do you have then for our listeners today?
Well, I fear that RISWA quantification, with all its scoring rules and the time intensiveness, the somewhat tedious nature of it, and the various approaches that aren't quite the same between different laboratories and methods, may seem overly complex and somewhat honestly off-putting for many clinicians and clinical polysonographers. I think I would emphasize that in most patients with suspected REM sleep behavior disorder, it's perfectly obvious on a general visual review of the recording when EMG activity is excessive in REM sleep. If one does need to quantify in more ambiguous cases or borderline cases, the cutoffs that I just mentioned would be the most appropriate. One final thing to emphasize is that regardless of the amount of REM sleep without atonia, if there's no evidence for clinical behaviors either from the history or recorded during the polysomnogram, the RISWA, the REM sleep without atonia, should be regarded as isolated RISWA and not RBD per se. But when you do recognize isolated RISWA in this fashion, it's always a signal that we should go back to the bedside and take a better history, or a more detailed history, at least, from the patient and their bed partner. Very importantly, seeking that collateral history often is telling because some patients don't know they're having the behaviors. That should always be the very next step and is often a revealing one when you find this on the polysomnogram without previously suspecting it.
Eric, thank you so much for sharing your expertise and your many years of work on the subject. I hope this has been helpful to our listeners.
Thanks so much for having me.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.